this is a critical focus, and we're so fortunate that a lot of research laboratories around the country are doing these kinds of studies. And I want to take this opportunity for anyone in the crowd or even online. Are we live broadcasting? To take questions that Dr. Baliga and Puchalski could talk about. So do we have any questions about some of the research they've discussed? I have a question. I know that we spoke briefly last night about immunotherapy, and for the people in the audience that don't know a lot about immunotherapy, in a nutshell, what we're looking for is something that tumor cells can express that will make them identifiable and unique, so that you can mount an immune response to them, and there aren't too many cells in your body. I mean, tumor cells also express things that are on other normal cells in your body, so how do you discriminate? But there was a concept that's starting to even preliminarily emerge, where you could potentially give some other drug that's already out there and available that may induce a specific type of molecule or protein only on tumor cells. And do you want to discuss that, and then how that might, this sort of synergistic treatment, synergistic therapy lead to?
Yeah, it's essentially what you described. So when you have neoantigens expressed on tumor cells, it makes them susceptible to attack by the immune system. But sometimes these antigens are not expressed necessarily on all the cells in the tumor, and so you don't have complete killing of all cells, and the tumor comes back. And often it can also be resistant to the primary immunotherapy that was used. So one way to address that could be to figure out what are the networks associated with the expression of the neoantigen, and look at even single cell analysis of the expression of that neoantigen across cell types and cells of a tumor biopsy, and then use that information to figure out if you can find drugs that can induce the expression of that antigen specifically. And so get more cells in the tumor to become sensitive to the therapy. Or you can also identify what are the other characteristics of subpopulations that make them resistant to immunotherapy. So you can predict other CAR T cell therapies that would be more effective in combination with rather than using a single.
Right, and we'll have a lot more discussions of immunotherapy. Dwayne?
Yeah, so I wanted to ask questions about the IP aspect. So one, obviously, impressive array and integration of information there. I wonder if you might comment on the effects of myeloid infiltrating cells or macrophages, tumor-associated macrophages within glioblastomas, which can sometimes be, to a third sometimes of the tumor mass, and either the ability to discriminate those factors, or thinking in the future the possible ability to look specifically at immune infiltrating cells and how their gene expression may impact on that.
Okay. Why don't you repeat the question so it'll be available to other folks?
Okay. I think the question is in regards to the myeloid infiltrating cells within glioblastoma. How can we detect these? How can we find out where they are? How can we monitor them within GBM? Is that fair? So we are interested in that. So as I alluded to in that last major figure that I showed, that complex figure where there's a relationship between the classification of the GBM samples, the RNA sequencing samples, and the phenotype signatures that have been published by their laboratories, that one of those signatures, or a few, were for immune cells. So we know that there's an immune compartment, so to speak, and that certain samples are enriched in these immune cells. So in our next steps here at the Ivy Center, what we'd like to do is do single cell analysis in each of those compartments, RNA sequencing. And we will probably use laser capture microdissection in order to isolate the RNA, or isolate the nuclei within those compartments. We will isolate each nucleus, do transcriptome profiling for each nucleus within each of those compartments. and then determine the cell types on the basis of those transcriptome signatures. So we hope to find the myeloid cells. We hope to find all the immune cells that might be represented in each of those compartments. Then we will have those transcriptomes analyzed for markers. We hope to identify markers that can detect those cells or specific flavor of those cells using antibodies or in situ hybridization probes and multispectral imaging on the tissue sections or adjacent to the original RNA sequencing samples, so we can monitor them. And then eventually, of course, we could generate antibodies to be used for FACS sorting of these cells from each of these microenvironments. And then we want to develop a slab culture system. We have a collaboration going now to do that, where we could grow certain microenvironments in a certain set of conditions so we can monitor these cells and treat them in drug screens to identify how we can knock out or perturb the system, especially for the cancer stem cells and for the immune cells. So those are next steps for us to do.
Question. Hey, Manuel.
Based on now you guys, two of you guys really give the big picture of the tumor and the information. So my question is next, when you go to the single cell transcriptome, because in the tumors there are actually the different subtypes of the cells. Even when we infect the different tumor cells, even the neuroprogenitor cells and the tumor cells, the SOX2 profiles totally different. So when you go to the tumor, they have different cell types. How we predict the outcome based on the information from the different cell type transcriptome information.
Do you want to repeat that? I'm not sure if I understand.
Yeah, so the question is, when you have heterogeneous cell populations within tumors, how can you make predictions of their behaviors when you have very different networks operating within them? The approach we've used can be applied to single cell data as well, and there are new technologies that are coming online to do hundreds of thousands of single cell RNA sequencings from single tumor biopsies. And so we can get that data, and using that data, we can then subgroup the cells, as Ralph showed in his work, into subpopulations. And within those subpopulations, every cell will be in a slightly different state, is expected to be in a slightly different state. And there has been some work that shows that you can, in fact, reconstruct relationships amongst the different cell types. And you can see differences in the networks. Even though the network is the same in a subpopulation, the network could be in slightly different activity states, and you actually see that. So we are able to then reconstruct de novo the networks within these subpopulations because of that variation. So the approach the application I showed you is on an averaged RNA-seq data set from each tissue. And we're looking at an average network, a dominant network. That alone has predictive value, as I showed. But if you can get to single cell level, I think we'll be able to get at the rare subpopulations, which are probably the main reason why you have resistance and recurrence and all of those issues, which probably are not showing up in these mixed tissue sample RNA-seq data sets.
Sometimes how you get the cutoff, they adjust the cutoff.
How do you adjust the cutoff? Cutoff for what?
When you say you average the...
Oh, well, the technology is essentially, it's not able to see differences across cell types. You're just looking at average gene expression changes across the entire tissue. So if there are changes that are in only small subtypes, you will not see it, and that change will be statistically insignificant. So you can calculate just based on statistics of that data set whether the change you observed is significant or not significant.
Oh yeah, Dwayne.
Question, just sort of more, maybe can both of you discuss the current level of integration between the analysis you're doing now and say, the routine clinical samples that are acquired in those settings? So can you integrate with either standard imaging or standard pathology samples that are required, and the same with your network mapping, or are there specific collection modalities and things that you've got to put in place to be able to do the analysis that you're doing? So kind of routinely, in the routine clinical setting, how applicable are these approaches going to be to the specimens as they're currently acquired?
Well, I can give you the question is, how is this approach applicable in terms of data generation in routine clinical
I
settings?
think he's also asking, what is the methodology from the OR to U that is required to do?
Maybe Charles should answer that question.
Well, I can certainly say that for the Ivy Allen Brain Institute project, it required the surgeon to resect the tumor en bloc, and then it was parsed up in a very meticulous way, and then sections were made in frozen section. Every other section had an H&E stain performed, and then the other section could be used for doing in situ hybridization or laser capture microscopy for gene analysis. So that was, not your standard, obviously your standard technique, but it's doable. And in terms of the other types of single cell approaches, we routinely take tumors from patients and they go to the lab and make single cell suspensions, grow them in stem cell culture conditions. But once you make a single cell suspension of a tumor, I guess it's available for doing some of these single cell analyses. But if you guys want to comment some more on that question.
So once you have a tissue single cell suspension, there are techniques such as drop-seq, where you have the reagents required for doing the sequencing in a bead. And so you can have every cell captured with one single bead in a single droplet. And then the cell is lysed open, and then all the RNA content is released. And the bead has probes for every single transcript. So you can then sequence the transcriptome, the entire transcriptome in that single cell. So that's called a drop-seq method. And there are companies that are bringing instruments online for routine applications. It's still state of the art. There's few people who are able to do it well. But I think in the next year, I think this will become a much more robust technology. And I think it can be used in a clinical setting if you can get the cell suspensions. And actually, there are papers on glioblastoma single cell sequencing. There's, I think, a paper that came out a month or 2 months ago where they did 100,000 cells from glioblastoma. There have been papers that have looked at 60,000 single cell RNA-seq data sets from PBMCs.